acute pancreatitis with bowel rest, IV hydration, and pain control. If the patient has passed and pancreatitis is mild, a cholecystectomy with IOC is indicated as soon as the pancreatitis has resolved. If the stone is obstructing the duct and pancreatitis is severe, an ERCP with sphincterotomy plus cholecystectomy is done. And it is strongly recommended that cholecystectomy be performed during the same admission, no? Because of the high rate of recurrence and increased morbidity of subsequent attacks of the pancreatitis. So please take note that the cholecystitis, as much as possible, should be done during the same admission. So another rare complication of gallstones is the Meritzi syndrome, where a stone is impacted either at the Hartmann's pouch or the cystic duct, which causes inflammation and eventually a cholecystobiliary fistula. So there are 5 types depending on the degree of biliary and other organ involvement. So type 1 is only compression. Type 2 to 4 involves the common bile duct with formation of a cholecystocholedochal fistula. While type 5 involves other organs such as the duodenum or transverse colon with formation of a cholecystoenteric fistula. So for type 1, the usual treatment is just to do a cholecystectomy. For type 2, since there's there will be chronic inflammation around the area and it's also involving the common bile duct already, a subtotal cholecystectomy is recommended. Well, for type 3, wherein it already involves 2/3 of the common bile duct, it's best to do a bile duct excision already and perform a bilioenteric bypass, such as a Roux-en-Y hepaticojejunostomy. So for type 4, it's the same treatment as for type 3. Whereas for type 5, it's basically the same treatment, but you include the closure of the cholecystoenteric fistula. So next we go to, in connection with that, we go to the next topic, which is gallstone ileus. No? So it happens when there is a cholecystoenteric fistula. So the stone enter the intestine and cause ileus if they become trapped in the ileocecal valve. So they can you can diagnose them in an X-ray. They can show pneumobilia, small bowel obstruction, and an ectopic gallstone. We call this the Rigler's triad. So for the treatment, actually the ectopic gallstone can either go to the proximal part of the duodenum or distally in the ileocecal area. So for proximal obstruction, you can remove them via an endoscopic approach. While for distal obstruction, you have to do an enterotomy and stone removal. For the cholecystectomy and closure of the choledochoenteric fistula, you can add it to the treatment if the patient is stable. But if the patient is not stable, you can just address it later. No? So next would be choledochal cysts. So there are 5 types. For type 1, it's a fusiform dilation of the common bile duct. The treatment for this is usually to do duct resection, cholecystectomy, and a Roux-en-Y hepaticojejunostomy. So the reason why we remove choledochal cysts is that it has a tendency to become malignant. No? And for type 2, you can do a simple cyst excision plus cholecystectomy only. Type 3, it is a cyst in the ampullary area. You can do sphincterotomy to relieve the possible obstruction in that area. Type 4A involves both the intrahepatic and the extrahepatic biliary tree. So you do cyst excision plus hepatic resection depending on where the intrahepatic cysts are located. Then you do a bypass through a Roux-en-Y hepaticojejunostomy. Type 4B is involvement of the multiple cysts involving the extrahepatic biliary tree. So you do cyst excision and Roux-en-Y hepaticojejunostomy. While for type 5, since there are multiple intrahepatic choledochal cysts, the treatment would be to do liver transplant if the patient will present with cirrhosis and liver failure. So next, so this is one of the favorite topics in the exams, no, bile duct injury. So I'm sure you're all familiar with the critical view of safety. So you have to fulfill all these three components to perform a safe laparoscopic cholecystectomy. So if you cannot fulfill this, then you can do bailout procedures such as the fenestrating and the reconstituting type of subtotal cholecystectomy. The most common cause is inadequate exposure and failure to identify structures, and only 25% are recognized at the time of surgery. So when you have a suspected bile leak or biliary injury, you have to, well, depends on the situation if it happens if it was detected intraoperatively or postoperatively, no? So these are diagnostic measures that can help you identify the bile duct injury. So intraoperatively, if you have a suspicion, you can do an IOC. You can do an IOC, and you can map out the biliary tree and potentially identify the biliary injury. For post-operatively, you can do an MRCP to map out the biliary tree, or you can do, if you can identify already the injury, or if there is any leakage, then you can use ERCP to put a stent and take care of the biliary leak. CT scan is usually used to detect intra-abdominal fluid collection, and if you have a drainage tube, let's say a PTBD or hepaticostomy tube, then you can use it for cholangiography to monitor the effectiveness of the therapy. So this is a sample algorithm for bile duct injuries. This is actually very complex, no? But just to try to make everything simple. So first, we determine if the bile duct injury was detected intraoperatively or postoperatively. So intraoperatively, when you detect bile duct injury, if there is hepatobiliary expertise, then you can proceed with immediate repair. If there is no hepatobiliary expertise, you can place a drain and transfer the patient to a tertiary hospital where a expertise is available. So preferably within 48 to 72 hours. So if there is a hepatobiliary expert, you determine if there are possible vascular injury. So if there is none, you classify the bile duct injury into minor or major. Minor, usually Strasbourg A to D. While for major, it's usually Strasbourg E1 to E5. So for Strasbourg's A to D or the minor bile duct injuries, they are usually being treated with repair, with suturing and T-tube placement. While for the more major injuries such as Strasbourg's E1 to 5, they are usually being treated with a bypass, which is a Roux-en-Y hepatic angiogenostomy. So on the other hand, if there is a vascular injury, I'm not so sure if they will go in depth in involving this vascular injury because it's quite complex, no? So if there is a right hepatic artery injury, you can just repair it. But if there's portal vein plus minus right hepatic artery injury, and there's liver injury, you consider doing a hepatectomy. But otherwise, if there is no liver injury, you can work up and delay the repair. So probably just try to focus on the one on the left, no? Not so much on the vascular injury part. So again, just to familiarize with the different Strasbourg types, no? So type A is there's a cystic duct leak. So if you detect this intraoperatively, you can just ligate the cystic duct stump. For Strasbourg type B, wherein there is the aberrant right hepatic duct has been ligated. So it depends on the size. If it's less than or equal to 3 millimeters, it means it's only draining one segment or a small part of the liver, so you can actually ligate it. But if it's more than 4 millimeters, it means it's draining more segments. So you have to establish it might cause some leakage, no? So you can repair it. You can establish the continuity of the bile duct. And you can add a T-tube or a stent to prevent stricture formation. For type C, again, it's more or less the same. It involves the right aberrant hepatic duct, but this time it's not being ligated, so there's leakage of the right hepatic aberrant duct. So if it's less than, as what I mentioned, if it's less than or equal to 3 millimeters, you can just ligate it because it's just draining a small portion of the liver. Well, if it's greater than 4, you repair and place a stent. For type D, wherein there's a lateral injury to the common bile duct, you can repair it and place a T-tube or a stent. For types E1 to E5, these are the more major bile duct injuries. So this, when you encounter this intraoperatively, for E1, since it's more than 2 centimeters away from the confluence, if there is no tissue loss, you can actually do an end-to-end repair with T-tube insertion. Or if there's tissue loss, you can use you can do Roux-en-Y hepatic angiogenostomy. With regards to the T-tube placement, if you have to do a separate choledochotomy and insert the T-tube, and one of the limbs should go across the anastomosis to serve as a stent, no? So separate choledochotomy. You can only if let's say for Strasbourg type D, if for the lateral injury, if the injury is small, it's less than 50% of the diameter, you can actually place the T-tube directly into that hole, no, in the injury. But if it's more than 50%, or if in case of Strasbourg E1, wherein there's complete transection of the bile duct, you have to do a separate choledochotomy and stent the anastomosis. For E2 to E5, please study na lang the description of each. You have to do a Roux-en-Y hepaticojejunostomy to establish continuity of the bile duct, no? So next would be, this is more complex, no? If you detect the bile duct injury after post-operatively, so you have to identify if it's a minor bile duct injury or major. So for minor, if there is a drain being placed by the initial surgeon, then you can just observe the output of the drain. If there is worsening or dumadami yung drain, then you have to subject the patient to ERCP stenting. But if it's decreasing and it will just close on its own, then you don't have to do stenting anymore. You can just leave the drain, then when it decreases, you can remove it later. In cases where there was no drain being placed, you can do if the patient is symptomatic, you can do a CT scan. You can check if there are fluid collections. If there is, you can place a percutaneous drain. And again, if there is worsening of the symptoms and if the drain is really voluminous, then you can do ERCP stenting. For patients with jaundice, you can do ERCP stenting directly. So now let's go to the major bile duct injuries, Strasbourg E1 to E5, detected post-operatively. So usually when they are detected within 72 hours, you can actually still do immediate repair, which is a Roux-en-Y hepaticojejunostomy. Provided this is being done by a expert. Then between 72 hours to 6 weeks, actually in this algorithm, they said it's 3 weeks because this is when the inflammation will start to decrease, no? But usually, I think it's more safer to do it after 6 weeks. Then if you are in this time frame, less than 72 hours to 6 weeks, it's best to tide the patient over to more than 6 weeks. So again, you can do a CT scan, you can check if there are fluid collections, you do percutaneous drain placement, or if the drain is continuously producing a lot of fluid, then you can do ERCP or PTBD, depending on which one will work, no? Then after that, once you tide the patient over to 6 weeks, then you can do the definitive Roux-en-Y hepaticojejunostomy. Yeah, so again, this is the treatment options for post-operatively, the different types of injuries. So type A, detected post-operatively, you can place a ERCP plus stent insertion. For type B, you can actually observe since there's no leaking of bile. But if there's worsening of symptoms, then you have to do a Roux-en-Y hepaticojejunostomy. For type C, since there's leak, you can do ERCP stent insertion. But if it does not resolve with ERCP stenting, then you have to do a Roux-en-Y hepaticojejunostomy. For type D, you do ERCP stenting ERCP stenting. Then for the major bile duct injuries such as E1 to E5, you do a Roux-en-Y hepaticojejunostomy. So we're almost finished, no? So for gallbladder carcinoma, you have to determine when they were diagnosed. So first, there are three scenarios. One is incidental finding of a suspicious mass during surgery, or you can find a mass on imaging or an incidental finding on pathologic review. So first, let's go with the incidental finding of suspicious mass during surgery. So if there is a expert available and it looks resectable, then you can proceed with a radical cholecystectomy. So you do cholecystectomy with en bloc hepatic resection of segments 4A and 4B. No, sorry, 5 and 4B plus lymphadenectomy. Then during the surgery, you have to submit the cystic duct stump for frozen section for the margin. If it turns out positive, you have to do common bile duct resection. But if it comes out negative, then you don't have to excise the bile duct. Then after, you have to work up the patient for proper staging, then give adjuvant treatment, which is also capecitabine. A biopsy is not needed during the surgery unless you have doubts in the diagnosis. So if there is no expert available, you end the surgery and refer the patient to a specialist or to a tertiary hospital. Again, intra-op biopsy is actually not mandatory, but can be done if there is a question with the diagnosis. So the second scenario would be when you detect a mass, a gallbladder mass on imaging. So you work up the patient, take tumor marker CEA, CA19-9. If it's resectable, then you do the radical cholecystectomy. Then give adjuvant treatment. Third one is an incidental finding and pathologic review after a cholecystectomy. So it depends on the level of involvement. No? So if it involves only T1A, then cholecystectomy is enough and you can just give adjuvant treatment after. But if it's T1B or more, then you have to go back and do the completion hepatic resection and lymphadenectomy. Then for patients with positive cystic duct node, it usually indicates poor prognosis. No? So you can consider giving neoadjuvant chemotherapy before doing the surgery. And also to address the micrometastasis. So again, for gallbladder cancer, it's important to draw the line between T1A and T1B. For T1A, you only do cholecystectomy plus the adjuvant chemotherapy. While for T1B, T2, T3, T4, you have to add the liver resection and lymphadenectomy and or extrahepatic bile duct resection. So for extrahepatic cholangiocarcinoma, so we discussed intrahepatic earlier. So now we discuss the extrahepatic cholangiocarcinoma. So they actually present more of jaundice rather than an actual liver mass. No? And again, it's important to take tumor markers, chest CT scan, just like any other cancer. So if it's resectable, we'll discuss the treatment options depending on the location. So first, we discuss first the perihilar location of the extrahepatic cholangiocarcinoma. It happens in 50% of cases. Then it depends on the type. So there's type 1, type 2, type 3A, type 3B, type 4. Please read up on the extent of the involvement. For type 1, we do bile duct excision plus lymphadenectomy plus cholecystectomy plus a bilateral Roux-en-Y hepaticojejunostomy. So again, all cholangiocarcinomas, you include lymphadenectomy. Actually, in the biliary tree, even the gallbladder cancer, because it is the most frequent site of recurrence. For type 2, it's the same treatment for type 1. Type 3A, now there's extension to the right intrahepatic ducts. So you involve a right lobectomy. For type 3B, there's extension of the left. So you include left lobectomy to the treatment. And for type 5, the treatment would be liver transplant. No? So in reality, because of advancements in surgical techniques, actually type 4 can be surgically resected. But for exam purposes, just follow what Schwartz said, that for type 4, liver transplant is the treatment. So for if any of these types are associated with primary sclerosing cholangitis, liver transplant automatically is the treatment of choice. So even if it's just type 1, but there is a component of primary sclerosing cholangitis, you do liver transplant right away. You don't do resection. So for hilar cholangiocarcinomas that are unresectable, you can actually check if they fulfill the Mayo Clinic criteria for possible liver transplant. So these are the components that you have to fulfill. And this is the regimen, the neoadjuvant chemoradiation for in preparation for the liver transplant. This is called the Mayo Protocol, Mayo Clinic Protocol. So next, we discuss the distal component of the extrahepatic cholangiocarcinoma, wherein it happens in 40% of cases. So the treatment for it is PPPD, pyloric preserving pancreatic ododenectomy, or Whipple surgery. And I think that's about it. Yeah, so this is the summary for the treatments of both gallbladder carcinoma and extrahepatic cholangiocarcinoma. So with that, thank you for listening, and I hope you learned something.
Okay, so thank you very much, Dr. Ong, for that very good lecture. I know it's difficult to compress all these liver and biliary topics in those very short time, but everything is covered naman, so thank you very much. We have one do you have any questions in the Q&A? So we have one. Okay, thank you very much, though. We have time for one question. So I have a phone-in question, Dr. Kyle.
Yes, sir.
Aside from the direct measurement of in relation to portal hypertension, aside from the direct measurement of portal hypertension and direct measurement ng pressure, and yung presence of the dilated veins in the abdomen or caput medusae, are there any other signs and symptoms that is non-invasive para masabi mo yung patient na meron siyang portal hypertension?
Well, clinically, sir, and radiologically, we can assess these. For example, let's say the patient on endoscopy presents with esophageal varices, then those can be signs of that will tell you that the patient has portal hypertension. And radiologically, if we see varices, if we see ascites, splenomegaly, these are signs that can tell you that the patient has portal hypertension.
Okay, thank you very much. Now, if meron kayong pahabol na questions, Dr. Ong is still here to answer your questions, but only through the through the question and answer or chats. So thank you very much, Dr. Carl Ong. Sana hindi ka nagsawa sa
Thank you.
invitation
Thank you,
natin for your review in the following years. Anyway, before we go to the next lecture on the pancreas and spleen, we have some words from our sponsors. Billy.
Hi, doctors. Actually, doctor, we have a speaker that we invited to discuss about the use of fluorescence imaging for surgery. Or just aligning the program. Tama ba, Dr. Uy? Yes po.
Okay, so we want to share the screen yung our speaker for today from RBGM.
Yes po. So good morning, everyone. So RBGM Medical Express Sales Incorporated has the mission to create partnerships with multinational medical device firms to promote, distribute, and deliver cutting-edge products and reliable service to healthcare units in the Philippines. So Getinge is at the forefront of pioneering advancements in healthcare as their mission to provide innovative products and solutions that enable better patient outcomes while enhancing health economics. Today, dear doctors, it is my pleasure to introduce our esteemed speaker, Eugene Lee, Regional Sales Manager, with a wealth of experience in the realm of medical technology. So he will just enlighten us on the cutting edge developments in new medical devices that are revolutionizing patient care. So the use of fluorescence imaging for surgery. Please join me in the extending a warm welcome to him.
Hello, good morning. Can everyone hear me?
Yes, sir, we can hear you, sir, loud and clear.
Great. I'm trying a new speaker here, so I hope everything is all right. Can you see the screen? Or is it the wrong one? Aika, can you see the screen?
Yeah, we can see your screen, Eugene.
All right,
Thank you.
great, awesome. All right, so I'm just gonna briefly talk about fluorescent imaging in surgery. So just briefly to tell you, my name is Eugene Lee. I'm the Regional Sales Manager for Southeast Asia. I work for this company called Getinge, and it's a Swedish company founded in 1904. So this year we're celebrating 120 years already. I just want to run through this very quickly because I think we are a little bit short on time. So we operate in the cardiovascular operating room, CSSD, and also intensive care segment in the hospital. And now today I'm not going to talk a little bit about our new company that we acquired in July 2022. The company is called Flu Optics. It's based in Grenoble, France. It's relatively new in this region. So just going to run you through the two things that we have. So these are how the two products that we have, FlowBeam LM and FlowBeam LX. This is how the product looks like. But I want to focus a little bit on the clinical side. So when we talk about fluorescent imaging, what happens is we have, can you see the cursor? Yeah, so what we're trying to do is actually trying to see blood flow. What happens is when you do an injection of a chemical called ICG in the human body, you excite it with the laser over here, and with the camera, you are able to pick up something called a signal from the ICG. Basically, from that, you can actually see blood flow. And what kind of applications are we looking at for blood flow? So let me jump through the next slide. So the light source through the excitation filter will excite the tissue, and then this signal will be picked up by the camera. So that's how the principle of the imaging works. All right, so I'll just talk about LM first. LM, light and memory. So the main clinical indication for a flow beam is blood flow and plastic and reconstruction. We can see the breast reconstruction, free flap reconstruction, imaging of the lymphatic drainage, and sentinel lymph node biopsy for a breast cancer patient. Okay, so just quickly look at the application one by one. When we look at sentinel lymph node biopsy, we look at the how the process goes. First, we use it to visualize the superficial lymph drainage. This is after 10 minutes of the ICG injection. It helps us to help identify where the SLN is. And from there, we can actually guide the surgeon for the incision. And then after that, we can actually confirm the fluorescence of the lymph node. And then you can look for residual fluorescence in the incision. So this is a lot of talking. Maybe let me show you a video how one of our KOLs from Paris does this case. So we start with the injection, wait about 10 minutes. During this 10 minutes, we can key in the data of the patient so that every case and video and photos recorded, you have some source to it. Strapped on the sterile cover of the camera, and then make sure it's tight, and then we are good to go. So typically what happens is we turn off the operating light during this procedure so that you can actually have lesser interference. And well, when you look at the camera, this is what you see. You can see where the perfusion of the blood vessel in the breast looks like. And then since there's a joystick there, you can actually adjust all your parameters and different types. And you can see we have pushed the lights away again because we want to confirm the incision is correct. And we take away the lymph node. And with the resected lymph node, we use it to reconfirm again. So it's used quite often intraoperatively just to check these kind of things. Yeah. So this is it. Right. Okay, so conventional method of this, people usually use either a blue dye, which is cheap and easy to get. However, there is quite a lot of staining that can happen and tattooing that can happen. And also the rate of allergy and anaphylaxis is quite high. ICG is actually a chemical that's invented since the World War II. It's very, very low allergy. It's quite easily to visualize, and then it does not carry the high the high requirements that you require when you use a nuclear medicine technetium-99 for detection. So it's quite a novel, simple method to get things going around. I'm just going to go through a summary of why it is better. The detection rate is higher. You can see things directly, and the whole pathway of this thing is very, very easy. And you don't need an expensive radioactive lab to set this up. And finally, the detection rate is extremely low. Right. Okay, now I'm just going to show you some things on skin sparing mastectomy in breast surgery. All right, so how do we use this? Just a second, let me put something down. So we have the mammary gland and the tumor. And what happens is when we do the cut and mastect, we want to sew the skin back again. So what happens is we need to use the fluorescent imaging to find out if there is any issues with the skin in the event there's any perfusion in the blood vessel. Otherwise, you face necrosis of the flap. So let me play this video and you can see. So the areas that are lighted up is actually areas that are perfused and well perfused. The areas that are darker you can see that the blood flow is actually not there. So this is actually very patient dependent because every patient is different. In the past, what we do is we use a skin prick or either touching to feel the temperature or the color of the flap to find out if there is sufficient blood flow. But using this fluorescent imaging, you get a more quantitative method of understanding if there is a blood flow or not. Okay, with this, you get a real-time perfusion assessment and monitoring to anticipate if there's going to be skin necrosis or not. So on top of that, maybe you think this black and white is a little bit uncomfortable. We can actually use it to a relative quantification method where you can actually see the results of how quantifiable it is, how non-perfused the green areas of the breast is. So this is relative. We can use it to indicate the 100% perfused area, and then we can see the green areas are the not very well perfused area. Right. Finally, I'll just talk about pre-flap surgery. So this is to help identify the perforator vessels where the patient is asleep before the clips are placed, and then you can design the flap before the removal. That you select the perforators before lifting the flap up. And then finally, after everything is done, you can assess the flap vascularization. Right. So we start with an injection, and then we use it to decide where the perforators are. And then we use this, as you can see the perforators are actually located already in this area. I'm not sure if you can see this video nicely, but yeah, you should be able to see the perforators now. Okay, something is going on with the video. That's all right. Right. Then the second part is the flap design. We inject the ICG again to locate the flap, the perforators, and we assess the perfusion. As you can see, the dark area over here is actually not very well perfused, and we have to think of a way to change the decision whether to preserve this, or how do we design the flap again. Right, you can see that how it is slowly vascularizing in the flap, and the black area is where it's not really vascularizing. Yep, so you can identify this area and maybe put a mark on it, and we have to redesign the flap in this area. All right, of course, we can also use a relative quantification method to actually see that this area is actually not very well perfused and a new design should be put in. Okay, so in conclusion, for reconstruction surgery, we can use the fluorescent imaging to help identify the vessels, assessment of the tissue perfusion, and we can make better design of the flaps, and we can identify these complications earlier on. Finally, for lymphedema surgery, we can also use it to assess where the problematic vessels are, and change your decision of treatment. So we have a mode called a panoramic mode, where you can acquire a series of images, and it will look like something of a long image, and you can see where the problem, where the blood flow is. So basically what's happening is actually you take the camera and put it along the limb, and you take a long series of images, and you have a very long image. So the end result will look something like this, where you can actually identify where how the blood flow in the lymph is. So with this, you can actually have an early establishment of the treatment that you want to go with that probably will improve your decision making and outcome. And this is probably the only way to visualize accurately the superficial lymphatic network on the arm. Okay, I will move to the next system we have called the FlowBeam LX. So this system is a little bit different compared to LM. So the X is actually the shape of the parathyroid glands, how it looks like over here. So this is mainly used for thyroid surgery. Contrary to LM, this does not need any injection of ICG. So during thyroidectomy, there are a lot of challenges. So the main challenges is to actually to localize and preserve the parathyroid gland. We need to make sure that is, because they are quite hard to see. The second part is to preserve the blood vessel, making sure that there is blood feeding the parathyroid gland. And after that, we want to know that the parathyroid gland is still well perfused. So what are the implications if the main complications for the patient after a total thyroidectomy? We have hypocalcemia, hypoparathyroidism. Basically, the regulation of the hormone is affected. All right. How can we carry out a better protocol? And these are the moments we can use. So using the FlowBeam LX, you can actually use this to detect where the parathyroid gland is. Do a very, very careful resection so that you don't throw them away, and then re-implant them, and then we check the perfusion again. So number one, I reiterate this point again, the parathyroid gland autofluorescence. It doesn't need ICG injection, but during checking for the perfusion assessment, we will inject ICG. Right, so these are the steps that they use. A section of the thyroid is removed and then re-implanted again. I'll just briefly show a video of this so that it will be easier for you to visualize it. This is the first step of the surgery where the early detection of the parathyroid gland is used. So I know a lot of trained surgeons are able to detect it by the eye. Of course, this is a secondary help for you to detect the parathyroid gland. As you can see the two little dots that it's shining on the camera. Right. And the next step is the identify the blood vessel feeding the parathyroid gland on the second phase of surgery. All right, so that is all for my presentation today. Please let me know if you have any questions about this, and we can arrange a more detailed presentation later on if you need it.
Okay, thank you very much for that presentation of your products, RPGM. Thank you very much.
Thank you very much.
Okay. Now to move on with our second part of our review, the pancreas and spleen, we have Dr. Charlene Marie Anlao, who is a fellow of the Philippine Society of General Surgeons. She has her GS residency from Cardinal Santos Medical Center and fellowship training in HPV surgery at the Rizal Medical Center. And she is also international visiting scholar in the Division of Liver Transplant and Hepatobiliary in Asan Medical Center, South Korea. Dr. Charlene?